Okay, let's start. Hello, everyone. Welcome to the White Army Interactive Indeed session. We have with us Dr. Nishanth Lakshmikanta sir, MS General Surgery, the patron of White Army, conducting this session on peripheral vascular diseases. Welcome, sir. We also have with us Dr. Krishna Rao sir, patron of the White Army, as a mentor. I welcome you, sir. We can start the session. Over to you, sir.
Yes, please. Thank you so much. Hello and very good afternoon / good evening to all of you. And hello, Dr. Krishna Rao. I hope you're doing fine and staying safe there. All right, so I'll get right into the class. So last time we discussed the chronic arterial diseases, and today we'll be discussing the acute arterial diseases. So just a small recap. So definition of peripheral vascular diseases is nothing but a decrease or a decreased tissue oxygenation, which can either be because of lack of blood flow or in general, a global decrease in blood supply. So for example, even if there is a reduced cardiac output, that also can lead to peripheral vascular ischemia. Okay. So whenever the oxygen demand is more and the supply is less, it will eventually lead to tissue ischemia and tissue necrosis. We saw the same slide last time as well. Peripheral vascular diseases is a complex of arterial, venous diseases. In arterial, it can either be occlusive or functional. Functional is when you have spasm and there is blockage of the artery, and the patient is usually, this is seen in Raynaud's disease. And in an occlusive disease, it can either be a slow and gradual occlusion, which is called chronic ischemia. We discussed this in the last class. Or you can have a sudden or a rampant or a sudden closure, which can cause acute ischemia. That we'll be discussing in this class. Okay, so acute limb ischemia is, like we discussed, is a sudden or abrupt occlusion of the arterial blood supply to the limb. Now, the most common causes are usually trauma and iatrogenic, but what's more important for you guys are arterial embolization and thrombosis. So you guys need to know the difference between what is an emboli and what is a thrombus. And in the second half of the class, we'll be discussing diabetic foot as well. Okay, because it's an important question and it's normally not given in a textbook for you to write a proper 10-mark answer for that. Now, coming back to this, embolism is basically derived from a Greek word called as embolos, which means plug. Now, what you have to understand in embolism is, although the artery is blocked, the cause for the disease is not at that particular site. The cause is somewhere else. For example, in a heart, especially, okay, that is the most common source in the heart. When they have atrial fibrillation or when they have some valvular diseases, there'll be certain thrombuses which are sitting on the valves. And suddenly when the heart pumps, this thrombus gets dislodged from there, travels through the aorta, comes down, and as the vessels, the diameter goes on narrowing. So when it reaches a particular threshold diameter, the thrombus sits there, it blocks, and the patient is going to have acute.
Yes, sir, audible, sir.
Okay. Yeah, I'm extremely sorry for the technical glitch. So I'll be presenting from my phone while Shravan will be changing the slides for me and he'll be helping me out. Okay, so like I was saying, for the embolism or an arterial embolism, the cause for the disease is somewhere higher up. Usually it's the heart. Sometimes even an atherosclerotic disease, probably in the aorta. Okay, that a small piece of the plaque might get dislodged from there and still come and cause embolism distally, probably in your popliteal artery or in your tibial arteries. So the disease need not be always in the heart. It can also be from an atherosclerosis from a slightly proximal artery. Now you also need to know what is called a paradoxical embolism. All of us know usually DVT, okay, which is the contrary to a thrombus in an arterial disease, deep vein thrombosis of a vein. Usually when they get dislodged, they go to the lung, okay, and cause pulmonary embolism. But they can also cause an arterial embolism, okay. That is when we call it as a paradoxical embolism. Normally what happens when there is a DVT in a leg, if the thrombus gets dislodged from there, it goes to the right side of the heart. From the right side of the heart, it goes to the lung and causes pulmonary embolism. If the patient has a patent foramen ovale, Once it reaches the right atrium, it can cross over to the left atrium, then to the left ventricle, then to the aorta, and it can still cause an arterial embolism. So that is what is called as a paradoxical embolism. It's extremely rare, but if somebody asks you, you just need to know what it is. Okay, could you please move on to the next slide? Now, what are the common locations of an embolism? The most common locations are the lower limbs. In the lower limb, the common ones are the femoral and the popliteal artery. Because usually the embolus is small in size, sometimes, very rarely, the embolus is so big that it might occlude even the aorta itself, okay, where there is maximum resistance and wherever there is bifurcation, because that is when the blood will not flow properly and the embolus can sit there and block it. Okay, so the large embolism, these are also called as a saddle embolism, and they block at the aortic bifurcation. In the upper limb, although it is rare, in the upper limb, it is usually at the brachial artery bifurcation and where the profunda brachialis artery originates. Okay, next slide. Now, you need to keep this in mind that an embolism is progressive. Okay, Shravan, can you just point the arrow at that silver area in the center of the clot? Yeah, in the center, higher up. Yeah, see. So that is the primary embolism. Okay, that is where actually the clot is sat. But what happens, it is progressive. So the clot will go on growing both proximally and distally. Okay, so you can see it looks like a snake now. So only the center part was where the actual block was, but then it went on progressing. If it is left alone without treatment, it can progress both distally and proximally. These are called as the tails of the embolus. Why is this important? This is important in our management, which we will talk later. Okay, next slide. Now we need to know what is thrombus. Okay, keep this in mind. Thrombus cannot happen all of a sudden like an embolism. Embolism can happen suddenly without any predisposing arterial disease. Whereas thrombosis is, there will be gradual narrowing. After a certain point, when it is narrow, when a small plaque breaks away, now you have a raw area there. Now in that raw area, platelet will come sit. You're going to have a platelet plug, and that will block off whatever little blood supply is going down. So usually these patients have a pre-existing arterial disease. Along with that, if you have certain other risk factors such as hypercoagulability, these can suddenly precipitate acute ischemia and cause thrombosis. Okay, sorry, thrombosis can cause acute ischemia. Next slide. So that's what I was saying. When a patient already has atherosclerosis, there is narrowing of the vessel. On top of that, if the patient has certain other risk factors such as decreased cardiac output, so that can also set in ischemia. And apart from that, if he has certain other conditions such as shock or septicemia, something which can decrease the cardiac output even further, that will also precipitate acute limb ischemia. Next slide. So I was telling you what are the other causes which can set in. Apart from atherosclerosis, the patient has hypercoagulable states. If he has like hyperhomocystinemia, or if he has any vasospasm, or if the patient has undergone some graft. Okay, we were discussing this last time for chronic limb ischemia. If you have put in a graft never has the normal endothelium what a regular blood vessel has. So again, that also gradually it will become narrow and it can cause blockage all of a sudden, and that can cause acute limb ischemia. Okay, next slide, please. So now this is the most important slide in the presentation. Okay, for you guys, you need to differentiate. If you write this slide, you're going to get most of the marks as far as I am concerned. You need to know what is the most important differentiating point between a thrombus and an embolism. Okay, so we've already discussed the first point. Embolism can happen suddenly because the vessel is normally patent and all of a sudden a clot comes and sits there. In thrombus, it is a pre-existing disease. So it will go on narrowing to a certain point and then it will get blocked suddenly. So it's a gradual disease which doesn't happen all of a sudden. So because it's a gradual disease, the patient will have some history of claudication, okay, because it is a chronic disease. Whereas embolism, he will not have any claudication. It happens all of a sudden. Now, if you can see the next point, when there is thrombosis, because I told you there is a pre-existing disease, it will not affect only one limb. It will affect both the limbs. So the pulse will be decreased or absent in both the limbs if it is a thrombus. Whereas an embolism, the pulse will be absent only in that particular limb. The opposite limb, the pulse will be there. Okay. And the source of the embolus, for thrombus, there is no source because the source is at that region only. Whereas in embolism, you need, if you do a echocardiogram, you'll eventually find a small clot or a mural thrombus in the heart. And diseases of the heart, such as atrial fibrillation, or the most common is valvular disease, what causes it. Now, if you can see the last but one line, the loss of function. In an embolism, it is acute because the limb has not got any time to get adjusted to the decreased blood supply. Normal blood is flowing, and all of a sudden it gets blocked, and the patient is in a lot of trouble. There is a rapid loss in function. Whereas in thrombosis, because it's a gradual disease, there will be small collaterals which have opened up, and the collaterals can hold off to a certain extent. But beyond that, even they can't help. So it is a sort of acute ischemia, but the patient can tolerate that ischemia for a slightly longer time when compared to embolism. So if you get an angiography done, in thrombosis, you can see I've written that it is tapered and there is an irregular cutoff. It is tapered because the vessel is diseased, so it will go on narrowing, and then at one particular point where the platelet plug has formed, it will get cut off, and beyond that you can't see the dye. Whereas in embolism, it will be completely normal and patent, and after that area it will get cut off because that is where the clot is sitting. Yeah, please move on to the next slide. So clinical presentation, how do these patients present to you? They actually, like we've discussed, the symptoms depend on the size of the artery, where the artery is, whether it is higher up or is it more distal, and whether collaterals have formed. So collaterals are more common in a thrombosis of the vessel as compared to an embolism. Now, when ischemia sets in, the first thing to be affected are the nerves. Okay, so first it affects the sensory nerves, then the motor nerves, and then the muscle. Okay, now common sense. For example, in a patient who has a trauma or in any sort of shock, whether it is hemorrhagic, whether it is septicemic, all of us know that the body is designed in such a way that it is trying to preserve the vital organs first. So it will protect, it will divert all your blood supplies from your periphery to your heart, the lungs, the kidney, the liver. Okay, that's why your peripheries become cold. The same way, in a limb also, the body will first let go of the skin. So it will start diverting all your blood supply towards your muscle. Okay, so the first thing to go are the nerves of the skin, then in that also the sensory, then the motor, and last one to go are the muscles. So first, if sensory nerve goes, the patient will have numbness. That is his first complaint. Then motor weakness sets in because of the motor nerves. The patient will not be able to move that limb. And on further progression, the patient will have muscle tenderness. So because the blood supply to the muscle is coming down, the muscle has ischemia now. So at any point, if the patient has muscle ischemia, that means he's almost at the end stage. And if you leave it further, the patient is going to lose his limb. Okay, next slide. Yeah, so now, can you just move on to the next slide, Shravan? I just want to see what is there. Next slide. Okay, come back. Yeah, thank you. One more slide back. Okay, so now you please understand, once ischemia has set in, there is no arterial inflow to the limb. So when there is no arterial inflow, the first thing to happen is the skin will become white. Okay, now just stay with me. After it becomes white, what will happen? Where there will be a certain auto-regulation which happens in the body. There will be capillary venodilatation, and then there will be some amount of venous backflow. Okay, and what will happen? The skin will become slightly blue in color, and if it persists, what will happen? Those capillary disruptions will occur, and blood will extravasate, and it will become really dusky. So it starts from being white to marginally blue, and then it becomes dusky. Okay, or it becomes really dark. That means it's going into the stage of gangrene, and the skin is no longer viable. So initially it's white. Go on to the next slide. Then what happens? It becomes marginally blue. So when that marginally blue is when there is capillary venodilatation. So when you press and lift your hand, that there will be a blanching. Okay, that blue color will give way and it will become white, but it will not again become pink. Normally what happens, capillary refilling happens when there is arterial inflow and the skin returns to normal color. Here it will not return to normal color. Once you blanch and it becomes white, it continues to remain white. Now we go into the next stage, that is the terminal stage. When the capillary disruption occurs, blood will extravasate and it is blood sitting beneath the skin. So there, even if you press, there is no blanching which happens. That means no blush. At this stage, it means that it is at the end stage and the skin is almost on the stage of necrosis, that is non-viable. And please keep it in mind, at this stage, just before we go to this point, just one more point. What happens when there is no arterial supply? Normal metabolism is aerobic metabolism, correct? So when there is no arterial blood supply, there is no oxygen. So the patient will have anaerobic metabolism. With anaerobic metabolism, there will be lactic acidosis. This lactic acidosis will be sitting there. And if you try to increase the arterial blood flow at this point of time, once there is a lot of lactic acidosis, if you improve the arterial inflow, this lactic acidosis gets washed off and it goes and sits in your kidneys or your liver to get metabolized. And this amount of lactic acidosis which is generated at that point of time can actually cause a damage. Okay, this is called as revascularization syndromes and what we call that. So it can actually cause damage to your vital organs, and because of the amount of acidosis which is sitting there, there'll be edema, and with that edema, if you increase the arterial blood flow, the patient can have compartment syndrome. Okay, so now coming back to how it sets in, the first thing to go is your skin. In the skin, it's the sensory nerves, so patient will have numbness. Then the motor nerves, patient will have weakness. Then he's going to have calf tenderness or your muscle tenderness. That means it is almost towards the end stage. So the skin will be pale, it will become slightly blue, and then it will become dusky, okay, when there is extravasation. So when it becomes dusky and when you press, there is no blanching, that means it's at the end stage. You can't delay his treatment any further. But keep it in mind, even treating him at that stage can cause complications because of the accumulated lactic acidosis. So the patient can go into compartment syndrome or he can go into renal failure. Okay, next slide. Now, I've told you this again and again and again. These patients, don't look at only the limb, look at the patient as a whole. Okay, so we have discussed that for embolism, there is a disease which is sitting in the heart. For thrombosis, there is a generalized atherosclerosis. So also evaluate the patient for cardiac and atherosclerotic disease. Okay, and you have to treat them accordingly, along with treatment of the embolism side by side. And even diabetes mellitus has to be looked at because they can have uncontrolled sugars when the patient is in sepsis. And if you try to intervene all of a sudden without controlling the sugar, the patient can land up in trouble post-intervention or post-surgically. Okay, next slide. So what are the findings that you will find when you see the patient? These are the 6 P's. It is given in all your textbooks everywhere. Pain, pallor, paralysis, pulse deficit, paresthesia, and perishing with cold. Okay, I don't think I have to elaborate this any further. We have already discussed all of this. Pallor will be there because there's no blood supply. Paresis or the paralysis is because of the motor nerve supply. Pulse deficit because there is no blood flow, so you won't have any pulse. Paresthesia is because of your sensory nerves, and perishing with cold is basically that because there is no auto regulation of temperature, because there is no blood supply, the capillaries, the arterioles can't do anything, the patient will feel like that his limb is being frozen. Okay, that is what it means by perishing with cold. Okay, yeah, next slide. So yeah, this is just a recap of whatever I've told you. If the skin is marble white or if he is white, that means it is an acute ischemia which has happened and it's the initial stage. If muscle tenderness is there, that means it is an advanced stage. That means you have left him for too long without, or he's come to you at a slightly later point in time. And if the pulses are normal in the opposite limb, that means it's an embolism. Or if they're absent in both the limb, think more in terms of thrombosis. Okay, next slide. So we have already discussed about the investigations in our last class. We're going to do a Doppler. We can get a CT angiogram, an angiogram, or if the patient has any allergy to dyes, then you can get an MR angiogram done. And last but not the least, a digital subtraction angiography. Please keep it in mind, Doppler has to be the first one. If needed, get an angiogram next. Okay, and then we'll take it up from there, how we are going to manage this case. Next slide. So any patient who comes to you, don't directly take him to the old operation theater and try to take out the clot. First and foremost, we have just said, what is peripheral vascular disease? Decreased oxygenation. So from your side, try to improve the oxygenation. Even if it's through collaterals, it will help. It will give you that golden hour of extra half an hour or 45 minutes or even 1 hour for you to get prepared in order to help him out. So first is oxygenation. Second is analgesia. He'll be in a lot of pain. So keep him comfortable, give him good analgesics. Even if you have to give him morphine, yes, please give him morphine as well. Hydration. The patient will be dehydrated, so hydrate him. And then we'll go into definitive management. And now we'll discuss what all is to be done. Next slide. Now, I want you guys to answer in the chat box. I've written anticoagulation first. Why do you think we have to give this patient anticoagulants? You can click it once, just click once. Yeah, so I've written here the first line of treatment is administration of heparin. So why do you think I have to give the patient heparin first? To prevent further embolism. No, embolism has already happened. Warfarin takes time for its action. Prevent small lymphocyte. And Tejaswini have answered correctly. I already told you, once an embolism sits there, if you don't do anything, it will progress both distally and proximally. Okay, you need to prevent this progression first before you do anything else. So anticoagulation, apart from being considered as a part of definitive management, it should also be considered as a part of first aid as well. Okay, so first is you're going to stabilize the clot by preventing further progression. Okay, so give him heparin. You click again, Shravan. So anticoagulation. So whatever thrombus is there, nothing. It's not going to do anything to the thrombus. It will only make sure that it will not progress. The clot or the thrombus or even your embolus will not grow further. Okay, next slide. Yeah, so now we go in for open. Can you just go to the next slide? We'll come back to this later. Yeah, so now with the recent advances, we have either endovascular or open surgical techniques. First, we'll discuss about endovascular. Once there is a clot sitting there, there are two things you can do. Either go in and manually remove the clot and come out through the vessel or through the blood flow or through the artery, sorry, or you give like how you give for heart, no, you give streptokinase, urokinase and try to dissolve the clot. So these are two things you can do. Either go manually remove the clot or go dissolve the clot. So to manually remove the clot, there are two techniques. There are actually many, of which for you guys, all you need to mention is two things. One is aspiration thrombectomy. You go there and you aspirate the clot into a narrow lumen. Or you do mechanical thrombectomy. You go there and you literally scrape off the clot. Okay, it's like your lithotripsy, what you do when you're doing it for urology. Small stones which are stuck in the ureter and which are causing hydroureter nephrosis. You take a small, either a small laser or small, ultrasound probe which vibrates really fast and breaks the clots and sucks it out. Okay, so that is what is being done. Can you move on to the next slide, Shravan? And the next one is thrombolysis. You take a small catheter there to that particular region where the clot is, leave the catheter there. The catheter will start giving out certain thrombolytic drugs such as streptokinase, urokinase, and it will dissolve the clot. So here in the image in the leftmost part, okay, where you can see the femur and the tibia joining. Shravan, can you just take the arrow mark there? You can see where the blood supply is cut off. Yeah. So beneath that line, there is no blood supply. So that is where the clot is. So in the image in the center image, you can see that the blood flow has kind of resumed. So that means your whatever drug you have given has started acting. And the one on the rightmost is showing that that is overlying the fibula. You can see that the blood flow has resumed and it has started flowing down into the limbs. Okay, next slide. So this thrombolysis has certain contraindications. Thrombolysis, you're giving streptokinase, and please keep it in mind, streptokinase will not act only in that part of the thrombus. It can cause bleeding everywhere in the body. So if the patient is already a known case of stroke, or if he is a known case of GI bleeding, either secondary to some ulcer or maybe AV malformation in the GI tract, or if he's undergone any intracranial surgery, or some neurosurgery. So these are absolute contraindications. In these three cases, you can directly rule out thrombolysis. So these patients either need to undergo that aspiration thrombectomy or that mechanical thrombectomy or an open surgery. So these patients can't be given thrombolysis. Now, the relative contraindications are if he has uncontrolled hypertension or major surgeries in the past 10 days. Why I'm telling you this is, for example, you have done a huge dissection anastomosis there. The wound is still in the stage of healing. If you give him streptokinase, he'll have hematoma at the site of that anastomosis, and the anastomosis will give way and he'll die because of sepsis inside the abdomen. So again, if a patient with major surgery in the last 10 days, again, it becomes a relative contraindication. Try and avoid thrombolysis in such patients. And these are candidates for the other mechanisms. Shravan, can you go back 3 slides to the open surgery part? Yeah, so now, how do we do an open surgery? In an open surgery, you're going to isolate that particular segment of the artery. You know where the clot is because you've already investigated him, you've got an angiogram done. Wherever the clot is there, make a small cut on that clot, remove the actual part. But you have to keep it in mind that these clots would have progressed a little both proximally and distally. Okay, so Shravan, can you just on that figure 1, yeah, see, you take the catheter beyond the site of the clot, and you inflate the bulb and slowly retract it backwards. So now you can see it in the next image. So as you're retracting it backwards, you're going to take out whatever that clot which is formed beyond the block. So you're going to take out that clot as well. So this is done in both the directions. You do it distally and you do it proximally. In both the directions, make sure you have taken out the entire clot. Now, at this point, please remember that you have made a cut in the vessel. Okay, so whenever you cut, there is a raw surface in the endothelium, and that is a site for development of a new platelet plug. So you have done your job. You have gone in, you have removed a clot, you have come out. But after closing, the patient can have a fresh clot there. Now, here comes the second role of that heparin, whatever you're giving him. That heparin will not only prevent further clot progression, it will prevent the formation of a new clot following your surgery at that particular region. So again, this is the second place where your anticoagulants play a very important role. Okay, so with this, I will finish my class on peripheral arterial diseases where there is acute. So recap, the most common causes are trauma. You can just move on to the next slide, Shravan. 2 slides later, I think once you reach diabetic foot, you can stop there, and yeah, you can stop there. Yeah. So now a quick recap of what we have done. The most common causes for an acute ischemia. So most common causes for acute ischemia are trauma and iatrogenic causes. But what you guys need to know is that there can be an embolism or a thrombus. Embolism will happen in a normal artery, but the disease is placed somewhere higher up in the heart, or a atherosclerotic disease in a proximal artery, such as a big abdominal aorta or common iliac artery or something higher up. Most common arteries to be involved: common femoral artery, popliteal artery in the lower limb. In the upper limb, it's at the bifurcation of the brachial artery. So coming to the physical findings, pathogenesis. First thing to be involved is the skin. In the skin, you're going to have pallor. Then the sensory nerves, patient will have numbness. Then the motor nerve, patient will have paralysis. Then the muscles get involved, patient is going to have pain. And when you squeeze his calf, he'll have tenderness. So that means it's an advanced stage. Now, investigation, you're going to go ahead with your Doppler, your CT angiogram, your angiogram. And if the patient has allergy to dyes, you get an MRI done. Management, first and foremost, is your first aid within the form of oxygen, analgesia, hydration. Along with that, give them heparin, anticoagulation. Then definitive management. It can either be open surgery or endovascular surgery. In endovascular surgery, you can have either thrombectomy or thrombolysis. Thrombolysis has certain contraindications. We have discussed that. And in thrombectomy, you have aspiration and you have mechanical thrombectomy. In open surgery, you directly cut open and you remove that clot and you put a catheter in and take out both the proximal and the distal clots. Okay, so this is in short about how we are going to manage an acute ischemia. Okay, so now coming to diabetic foot. Okay, why I have chosen this topic is, and I will answer your doubts again at the end, because I'm using my phone. It becomes difficult for me to switch between slides. Guys, I'll answer your questions. You can again post them at the end so that I'll be able to read them completely and give you the answer. Now, why I have chosen diabetic foot is, diabetic foot is a very, very complex disease, which they conduct CMEs for 2 to 3 days and so on. But I have shortened it to as much as possible for you guys, enough so that you can write a 10-mark answer when asked on it. Please keep it in mind, diabetic foot is always a triad. Okay, a triad of the ones in the red I have written: neuropathy, ischemia, and infection. Okay, and invariably at least 2 of these will be obviously evident before a patient, or if a patient has an ulcer who comes with you with a diabetic ulcer, definitely 2 out of the 3 will be 100% there. Okay, next slide. Okay, so before we go into that, just a small recap, okay, of our foot. The most important thing here is there are 2 arches. Okay, we know there is a longitudinal arch and a transverse arch. Shravan, could you just show them the longitudinal arch? That's the thin red line. Yeah, that is the longitudinal arch, and the fat red line is the transverse arch. So what happens is, which are the normal pressure points now? One is the calcaneum, that is near the heel. Can you just show the heel, please? Yeah, 1 point is there. Second is near the ball of the great toe, ball of the great toe and ball of the little toe. So this is where your pressure is felt. Okay, these are the pressure bearing points. Why it is important, we'll see in the coming slides. Next slide. So we talked about neuropathy. So this diabetes can affect all 3 nervous systems: sensory neuropathy, motor neuropathy, autonomic neuropathy. How it does? Once there is sensory neuropathy, the patient will not have any sensations. Okay, so that will give way for him to, that will allow certain traumas to go unnoticed. Like he'll start walking barefoot, he won't realize when a needle pricks him, he won't realize when a nail pokes in, he won't even realize that he's sustained a wound, and he'll continue to walk. So that will allow infection to set in. Okay, so it will give a portway for infection to enter the foot. That is how sensory neuropathy plays a role. Now, motor neuropathy. Now, in motor neuropathy, we know that the foot has arches. These arches are maintained by certain muscles. So if these muscles give way, the arch of the foot is lost, and the patient will either have a flat foot or he'll have that rocker bottom foot. So now the pressure is on other areas of the foot where pressure is not meant to be put on. Like, for example, if you try to walk on your knees and your elbows, please realize you're going to end up badly hurting yourself, because they're not meant to lift weight, or they're not meant to sustain the weight, your elbows and your knees. When you try to crawl after you become an adult, please try crawling. You can't, because your body weight is so much and your knees and elbows can't take that weight. So the same thing happens here. Your heel and your ball of your great toe and little toe are what is meant to take the weight. But once these arches are lost, the other areas start to bear weight. They will have trophic ulcers there, and again that becomes a portal of sight for infection to come in. Now the autonomic nervous system, that gets involved. So normally you sweat and your skin is kept moist, or there is certain secretions from your palm and your skin which keeps your skin moist. Now that is affected. So now the patient has a dry skin. So when there is dry skin, higher chances of fissures, cracking, and infection setting in. So in this slide alone, we have discussed 2 out of the 3, how neuropathy and how infection plays a role in diabetic foot. Next slide. So this is what I'm saying. The top left is the arches, what we just discussed. And in the bottom right, you can see wherever the red area, okay, the bright red area, the heel and the ball of the great toe and ball of the little toe. That is where the pressure is supposed to be. But what happens once the arches are lost, the area in the blue and the green, what you see, they will start bearing weight, which they are not meant to. They will develop a pressure ulcer there, and that will act as a portal of infection. Next slide. Yeah. So we have discussed 2 out of the 3. We have discussed neuropathy, we have discussed infection. Now coming to peripheral arterial disease. Simple. Peripheral patients with diabetics have a 4-time higher chance of developing peripheral arterial disease. And so far over the last 2 classes, I've told you how peripheral arterial disease can lead to the formation of a non-healing ulcer. But please keep it in mind, in diabetes, apart from macroangiopathy, even the smaller vessels, the microthrombi are formed. So each patient can also have microangiopathy. So a patient with a diabetic foot, even if he has a normal dorsalis pedis pulsation, that means his bigger vessels are normal, but the smaller vessels beyond that, their scapulary, their arterioles, they might not be functioning properly. So don't take it for granted just because your Doppler is normal, artery is normal. Don't take it for granted that, oh, this fellow doesn't have any ischemia. He only has neuropathy and infection. No, there will be a certain degree of microangiopathy. Okay, next slide. Yeah, I think I've covered the same thing in my pathogenesis. You guys can read it later. It's the same thing. There is a trauma which he doesn't notice, and then the pressure falls on the wrong area and he'll develop a new ulcer there. Next slide. So this is given in all your books. You have to mention this. What is Wagner's classification? You need to mention this. I will not repeat this. This has no bearing for me, except that if the patient has class 4 or class 5, that is grade 4 or grade 5, he has gangrene or gangrene of the entire foot, he needs some sort of surgical amputation. Okay, we'll deal with that in the coming slides. Next slide, Sean. Now coming to management of a diabetic foot. Okay, if you write these 5 points, you have got most of your marks. Apart from your pathogenesis, and you write these 5 points, you have got most of it. You need to elaborate a bit more on each of those. Vascular supply. Okay, we have already discussed diabetics have a 4 times higher chance of developing PVD or a peripheral arterial disease. So if these patients can be stented, or if you need to start them on certain medical management to improve the blood flow, please do it. It will help in improving the ulcer. Infection control. Give them broad spectrum antibiotics first. Then take a wound culture, take that swab, see what organism grows, see what antibiotic is sensitive to that particular organism, then give him that particular antibiotic. Done. Third point, pressure offloading. We've already told, if they have to get certain special footwear done, certain special footwear or casts done, which will prevent pressure falling from that particular area of the foot, which is not meant to lift pressure. So they'll have a small bridge in the shoe. The shoe will not be flat like all your Nike, Adidas and all. There'll be a small bridge there over which his foot will sit. So that particular area, there'll be a cushion there which will prevent pressure falling on the area of the foot which is not meant to bear weight. Next, S, you're going to have debridement, either sharp or surgical debridement. And finally, last but not the least, common sense. If he is diabetic, he will have uncontrolled sugars. Please control the sugar. Now, because of surgery class, I'll just elaborate a bit more on surgical debridement and amputations. I'll repeat myself again. For vascular supply, if the patient has to be stented or he needs pharmacological therapy to improve the blood supply, please give it. For infection control, start him on broad spectrum antibiotics, take a culture and then start him on organism specific antibiotics. Then pressure offloading boots or pressure offloading casts in order to prevent pressure falling on areas which are not meant to bear weight. Next, surgical management, either in the form of debridement or amputation. And last, adequate sugar control. Okay, next slide. Now, why do you need debridement? Why can't you just control it with antibiotics? One thing, if there is an ulcer or a diabetic wound, it can go on spreading higher up. So what is in the diabetic foot might end up becoming diabetic leg. Okay, the infection might spread higher up. Next, if higher up, if it spreads along the fascia and the skin. But what if it spreads deeper? If it spreads deeper, it's going to affect the bones and the patient might end up with osteomyelitis. Please keep it in mind, once the patient develops osteomyelitis, you're looking at a very long course of recovery. So don't wait till you get to such a stage. That's why take off or do a debridement before it reaches that stage. And osteomyelitis will be picked up faster on an MRI than an X-ray. So if you just do an X-ray and say there is no osteomyelitis, that is not justification. Only the end stage, once it becomes that sequestrum, only then you can see it on the X-ray. The initial stage will be picked up only on an MRI. So finally, if you don't do a debridement at the right time, the patient will either end up with amputation or he'll end up in sepsis, where the infection spreads all over his body. Okay, next slide. So what are the techniques of debridement? Okay, you have autolytic, biosurgical, ultrasonic, hydrosurgical, and surgical. Next slide. So what is autolytic debridement? Basically, you're going to cover that area of the wound with a certain sort of dressing, which releases certain proteolytic enzymes. So along with the tissue fluid, which is released along and the proteolytic enzyme, it digests the slough in that particular region. Okay, so you don't have to operate. So you just by using a certain sort of dressing, you can cause sloughing off of all the necrotic material there. Okay, next slide. This is called autolytic debridement. Next, you're going to use biosurgical. Here, you're going to use certain medical grade larva. Don't, if some patient comes in walking in with a badly infected wound with maggots, don't tell him, no, debridement is already being done and don't send him off. No, please don't do that. This is only for theoretical purpose. The larva of bottle green fly, okay, these are the medical grade larva which feed on necrotic material. So they are being used to take away or eat away certain slough which is sitting on the wound. Okay, next. Next, ultrasonic debridement. You're going to use a certain sort of an ultrasound probe which vibrates at a very high rate, that it sloughs off or it debrides a layer of the infected or the necrotic material on the wound. Next slide. And next is your hydrosurgical. You can see on the image on the right side, the water comes in a very high rate in a circular fashion, and it develops a sort of vacuum. So apart from washing the wound, the vacuum also sucks out all the dead material. Please remember, healthy material is usually has its own blood supply, so it sticks well to the base, or the granulation tissue sticks well. It's only the infected or the necrotic material which doesn't have a good blood supply that gets sucked off when you're using this hydrosurgical method. Next slide. And last but not the least, this is what we do, a proper surgical debridement, where we take out a good chunk of infected tissue with a rim of normal tissue, or we debride up to healthy tissue. That's what we say. Till we see fresh bleeding, we go on taking layer by layer by layer till we see fresh bleeding. That is called surgical debridement. Now, whatever I've told you in detail, we can go on and on about all of this in depth. But for you guys, for an exam, you need to know what it is, or in the Viva, if they ask you, you need to know 1 or 2 words about it. And that is what the information I've given you and the names of the procedure. Okay, next slide. So now, what are the principles of debridement? Never try to do it under local anesthesia because of 2 things. What you see on the roof is not what is in the base. So an ulcer might be 1 into 1 centimeter, but the infection underneath might be 5 into 5 centimeters. So if you give local anesthesia only into around that 1 into 1 centimeter wound, you won't be able to do a proper debridement. It will be a half-hearted job. That is the first thing. Second thing, local anesthesia is a basic compound. So it will not act in a infected acidic environment. It will get neutralized. So always do it either under regional anesthesia or do it under general anesthesia, whichever is preferred at that particular point in time. So give him good anesthesia and then do it. Incisions. Incision should be placed along the tendon of the muscle. Okay, for example, tibialis posterior from the sole. That is because infection spreads along the fascia of the tendons. So don't put a horizontal incision on the foot. That is wrong. Always put an incision along the tendons, and there are certain compartments in the foot. I'll not get into it because it's more of a surgery or a postgraduate topic. There are certain compartments in the foot, and all the compartments will be exposed when you put an incision along the line of the fascia or along the line of the tendon. Next, inspect the wound, see all compartments, make sure you have exposed everything. Next, do a formal debridement where you take out as much infective tissue as possible and then give a good wash. That is what we call as a wound lavage. Okay, next slide. Now, amputations. I know as a surgical postgraduate, we are more enthusiastic to operate on amputations, be it as small as a ray amputation or below knee amputation or an above knee amputation. We're very happy with it. As soon as patient comes, we are trying to push him into the OT and do this surgery rather than doing a debridement. But please keep it in mind, even when something as small as a ray amputation, 70% of these patients will eventually die in the next 5 years because of certain complications. The higher the level of amputation, higher is the mortality. So a patient with a ray amputation has a higher chance of survival than a patient with a above knee amputation. Don't think you've done a great job by taking off entire infection and doing a higher up amputation. Studies have shown that they actually have a higher mortality. That is because the disease, not because of your surgery, but because of the severity of the disease. And 50% of these patients will end up having amputation even in the opposite limb in the future. Okay, next slide. Now, I will not go into in-depth details of the amputation. I want you guys to understand the concept, okay, why we do an amputation and how we do an amputation. How is it different from a ischemic amputation? In an ischemic amputation, wherever you have blood supply, you're going to cut off to that region, okay? It might be even a radical amputation. Whereas in a diabetic amputation, it is amputation done for infections. So in infection, you have to be as conservative as possible, because you've just told the higher the amputation, higher is the mortality. So try to be as distal as possible while removing as much infection as possible at the same sitting. Okay, so it has to be a conservative amputation. And like I've told you, preserve the ball of the foot whenever possible. In the ray amputation also, if you can preserve the ball. So don't crush the head of the metatarsal. I am sure all of you would have been taught, after disarticulating, crush the head of the metatarsal so that you'll have granulation tissue which comes out from the bone marrow. No, but you're doing him a big disservice by taking him off the pressure points. Okay, so don't crush the head. That is not to be done. Next, try to remove as much infection as possible. Along with an amputation, do a debridement also. Try to remove as much infection as possible in the same sitting. Don't expose him to repeated procedures or repeated anesthesia, because you're increasing the risk. If the bone is involved, try to take out the bone as well. Do like if an osteomyelitis, that particular bone is gone, take it out. Next, in the presence of infection, don't try to close the wound. If you close the wound, the pus will stay inside and it will cause sepsis. Rather, leave the wound open, let the pus pour out. Okay, so the patient will have a better chance of survival then, rather than trying to close the wound and being happy, or you have a satisfying your pride saying, see, I've done an amputation, I've closed it, the wound looks so beautiful, and you take a photo of it just by giving some betadine peroxide wash there. No, even if you have a 5% chance, leave the wound open, wait for 2 to 3 days, give him high-end antibiotics. Then if you want under local anesthesia, you can always suture the wound. No harm done. Okay, you're doing a patient a huge service by doing that. Okay, is there anything left in the next slide, Shravan? Okay, so just one slide back. So I'll just recap diabetic foot for you guys to write a 10 marker. It is a triad of neuropathy, ischemia, and infection. Neuropathy in the form of sensory, motor, and autonomic nervous system. We have discussed how. Infection, we have discussed how, because it's a part of neuropathy. Coming to ischemia, they can either be major macrovessel disease, macroangiopathy, or microangiopathy. Don't keep always keep microangiopathy at the back of your mind. Then pathogenesis, we have discussed how it happens. Next, coming into classification, you have to write this classification. Then coming to the treatment part of it, you have to manage it under these headings. Write one or two lines about all of this. Whatever I've told you, you're going to get most of the marks there. Vascular supply, either by revascularization and giving him drugs, infection with antibiotics, pressure offloading with certain different types of boots, surgical debridement, we have discussed. There are many different ways, autolytic, biosurgical, etc., etc. Then adequate sugar control. And at the end of surgical debridement, you need to tell why you're doing the debridement. Next, what are the principles of putting what anesthesia are giving, how the incision is being put. And next, with amputation, you're going to do a conservative amputation, and in the presence of infection, you're not going to close the wound. If you write this much, trust me, you have written more than enough for a 10 marker, and you have a concise answer which covers everything rather than straying off topic. Okay, so with that, I'll finish my class where I've covered acute ischemia, secondary to embolism and thrombosis, and a short lecture on diabetic foot. All right, so I'll be happy to take all your questions now. The first one is, sir, when we give oxygen or any of the initial management, won't that cause reperfusion injury or compartment syndrome? No, it will not, because compartment syndrome would have already set in, and it is distal to the site of the block. Your oxygen, you're trying to help him by improving it through the collateral, so you're not going through the major vessel. Next, what is Homan sign? Tenderness or resistance to passive dorsiflexion of the foot. Please keep this in mind, Norman. Homans and Moses. Remember, Moses is something similar to massaging the foot. So squeezing is like massaging the foot, that comes under Moses sign. Homan sign is forceful passive dorsiflexion of the foot. Okay. Next, should the tendons be cut in wound debridement? No, it's only the fascia. Okay. Avoid cutting tendons as much as possible, because if he's not already developed some sort of motor neuropathy, if by chance he's not developed, you by cutting the tendons will definitely give him motor neuropathy at that point of time, because he loses arch of the foot and stuff like that. So only remove whatever is necessary. Sanjay, why is there higher mortality in higher amputation? I just discussed. It's not because of your procedure. Higher amputation means the disease has become so bad that he had to lose so much of a foot. And just by doing an amputation, you will not cure him. It will worsen and he will die because of the severity of the disease. If not this limb, he'll end up with that limb or with progression of the disease over a period of time. Okay. Then somebody has asked me, is hydrosurgical the best method of debridement? No, it is a combination of everything. The best method of debridement, as a surgeon with pride, I will tell you, it is surgical debridement. Okay, it has certain roles and it is surgical debridement. Your hydrosurgical and all, you would have seen after surgery, 2 days later, you will open the wound, there will be a little bit of slough and all. To remove that slough without causing the patient much of pain, you can use all your other modes of debridement, such as autolytic, biosurgical, hydrosurgical, ultrasonic and all. But to cut and incise, you still need a surgical debridement as a primary modality. Oh, Srinivasan sir is on YouTube. Sir, good evening, sir. I hope you're having a nice day. All right, then. Any other questions, guys? Wait, I think I saw something in the starting. No, that's all.